Who would like to answer that, Joanna? Do you think?
It depends what drugs you're talking about and what problems you're talking about. And if you want to stop people talking about their symptoms, quite a lot of these drugs can do that quite effectively. Especially antipsychotics. Whether, obviously that's not really helping the underlying problem. And I think we're not thinking clearly enough about what the real problems are and what drugs can actually achieve. And I think we've got completely overblown ideas about what drugs can achieve. I think they can do some things. They can reduce arousal, and that can sometimes help reduce anxiety, some sorts of drugs. Reduce mental arousal, damp down hallucinations and psychotic thoughts for a while. But I don't think that they reverse anything. I don't think there is any drug that improves mood. I don't think we've got any evidence that anything improves mood, other than the drugs that induce euphoria in the short term. But that's a rather different thing. And obviously, it's really important to balance. This is a big question, because if you're prescribing something that's useless and has harmful effects, you shouldn't be doing that. Okay, but I can send people some if they're interested. I'll just respond to that question. Thanks very much. I completely agree with you. Something I'm really concerned about and seeing at the moment is staff minimising the metabolic effects of olanzapine and clozapine, and they say, oh, they're putting on weight, but they're eating too much, and blaming the person when we know very clearly that these drugs increase appetite, and not only increase appetite, but produce this really strange craving for junk food and sweet food and carbohydrates, and we know they do that. But I just wanted to make another point. That I think one of the reasons that sometimes doctors don't listen to complaints is because they can't always do anything about them. And I think we do have to acknowledge that there are limitations to what doctors can do, and that sometimes they're being asked to do things that they are not able to do. It's wrong that they're not able to acknowledge that. It would be better if doctors were better able to say, well, actually, we can't do anything, or all we can do is this. But I think sometimes they are being asked to solve things that it's not easy to solve, and that they don't have the tools to solve.
I think the result of that is very often a denial I find this very frustrating, that what lay people seem to be able to see, GPs and psychiatrists are so often in denial about, that the drugs are actually producing a lot of the adverse effects that patients are presenting with. And no amount of coaxing or arguing with these doctors seems to bring them round to agreeing with that, and that just seems quite bizarre to me. Dad, come in.
No. I think it could be a little more tricky in that it's a bit like maybe going through labour or whatever. What you've got is the people who actually go through the system can see the things that you say. But all the rest of the people out there in the wider world look at the system and think there's hospitals, there's medicines, we should be able to treat these illnesses, and the doctors say they're doing a good job, and they're going to believe the experts and not the patients. And even your husband and wife is probably going to take the side of the doctor and not yours, So
yeah, I know, that is an issue.
I mean, you really have to be in there first and see what happens before you realise what the problem is.
Yeah. That's why I wanted to come back to what you said about working on a ward and knowing all the negative effects, but not giving them to either the person who's having psychotherapy medication or their family. I think that you should be doing that. That it's one of your main responsibilities to say, you can take these drugs and they might help you like this, but these are the negative effects, and that's proper. That's a choice. But I know that a lot of ward staff don't do that. I worked on wards for 10 years and constantly got into conflict with my colleagues because I would do that. I would say, okay, you can take this, but if you take olanzapine, it's likely to make you fat. It's something we know that happens. And we have to tell people that. The other thing is that, like you were saying, people come to the system. There's more than one way to understand what we kind of experience. And while psychology, sociology, and psychiatry has a dominance of it, this will keep continuing to happen. We have to kind of look outside as well. alternative.
But I think there's no excuse for people being prescribed olanzapine when they blatantly have a family history which shows that it turns them into a ticking time bomb. I've got a client who is going to be this week, whose mother died a few months ago from a heart condition, age 65, whose father is a diabetic, and 6 months ago was prescribed olanzapine and has ballooned in weight. And to me, he's now just a ticking time bomb unless we can get him off the olanzapine and try and get his weight down and so forth. And to me, that's unforgivable because it's a well-known fact now that olanzapine has that effect, and to give it to somebody with that family history who isn't even, there's no psychosis, it's purely for anxiety, is just crazy.
Can I add 2 points towards medical education? Number one, we teach medical students on how to take histories from patients, but nowhere in those histories do we take a psychiatric history from patients. You often get medical students that come back, they get details that the patients had a toenail extracted or something, ingrained toenail extracted in 1957, but then when you get the drug regimen described to you, you find out that they're on olanzapines, or they might be on an SSRI. In other words, it's not included in a basic history taking. Getting a psychiatric history from the patient is often overlooked in all the clinical examination textbooks. It's not included. The second point is in medical education is knowing about the drugs that you prescribe and in the very basics of the drugs, because often withdrawal side effects from drugs are due to relatively short half-lives. We know that we've described earlier about lorazepam and the short-acting SSRIs like paroxetine, and short-acting opiates such as tramadol, a very frequently prescribed opiate in general practice. Trying to get those patients off of those drugs is impossible. You have to switch them to longer-acting versions of those groups of drugs and get them off that way. For example, with tramadol, I know somebody who's trying to get somebody off by gradually reducing the dose of tramadol, somebody who's addicted to 500 milligrams a day of tramadol. And there is plenty of literature available that suggests that you can switch those patients to methadone, for example, to bring them. And it's almost impossible to bring somebody off of a short-acting drug, whether it's an SSI, benzodiazepine, or an opiate. So it's really getting basic medical education out there as well.
I think you agree.
So could I just
Sorry,
ask
Jo,
you,
yeah.
is that definitely true? Because I remember working in addictions that there were some addicts who preferred to come off their heroin, go to bed for a week and get it over and done with, rather than go on methadone and have months of withdrawal. And I'm not always sure that it is always the right thing, and obviously it depends. It's an individual
I think
decision.
we're down back to the individual, aren't we? Not one size fits all. Looking
we
at
found that
the individual.
kind of, because I've supported people to come off medication, and some people, like with smoking, they get up one morning and say, right, that's it, I'm stopping, bang. And whatever withdrawal state they go through, they just manage it. And for some people, it's far too difficult just to do that like that. And you can't predict who is going to be able to do that. You can't say you're going to be able to stop like that. It's just not predictable.
I think we need to learn something from the area of addictive behaviours. The treatment for people who've got long-standing alcohol or opiate problems always involves helping them to readjust to a drug-free life. And I think that people who've been on psychiatric drugs may need some of the same sorts of help.
This lady would just like us to finish.
So this notice, which is in bright yellow and black lettering on all the inpatient acute wards and outpatients, etc. In Sheffield, it says, there are no secrets about medicines. Patient information and advice leaflets are available. Please ask the ward and pharmacy staff or contact the chief pharmacist. There are no secrets about medicines, not in my experience, not in my researching. There are so many secrets which are not divulged or shared to carers or service users.